For our last speaker of the morning, I again like to introduce Dr. Hari Tunuguntla, and close. And he's going to speak on urologic kidney type disorders, so give him your attention. And as soon as he is finished, he's going to be joined up at the speaker's table by Dr. Schleminski and Dr. Golby, and they will take questions from the floor. If you raise your hand, we'll come around with one of the wireless mics. We're going to put them at stationary mics, and then we're going to take their roving mic away, and we'll be out in the audience. But if you've given us questions on postcards, we'll try to see that those are answered also. And without further ado, Dr. T.
Thank you. I'm a urologist, basically. I have special interest in neurourology and voiding dysfunction, urinary incontinence, all types of bladder problems. The most complex part of the problem, MSA, and the complex pathophysiology and treatment was already discussed by the great speakers, Dr. Golby and Dr. Chalimsky. I really enjoyed and learned a lot of things. So my part is very simple bladder problems. So let's see. So in this, I just wanted to discuss what are the various types of bladder problems and then how we can arrive at a diagnosis and how we treat them. So it's very, very important, like many of the bladder problems in MSA, like any other neurological problems, can present similarly. So the treatment is not the same in all the patients. So it's very, very important to exactly know what type of the bladder dysfunction is there, and then tackle that problem rather than empirically treating each and every patient with similar medications. It's extremely important to qualify the type of bladder dysfunction in these patients. So the urination is a very, very complex, but it's a very coordinated event, physiological event, and it requires a very good coordination between different parts of the nervous system, starting from the higher centers in the brain, the spinal cord, and different parts of the nervous system like the sympathetic, parasympathetic, somatic nervous system. There are different parts. So we need to have intact innervation and neural supply of the urinary tract to have well-coordinated the process, the phenomenon of physiological phenomenon of urination. So basically, there are, in the brain, Dr. Golby has already discussed about the brain stem, the midbrain, pons, medulla, and there is a center, there is a collection of nerve cells in the middle part of the brain stem, the pons, which is also called pontine micturition center. So basically, it is like a policeman for the normal urination to take place. So if there is any problem there, like any part of the CVA involving that part, can obviously disturb the normal urination. And in addition, it controls the cells, the nerve cells take the sensations from the low urinary tract from below upwards, and then the higher centers, the micturition centers in the brain, and they also they come down through the nerve cells. So the pons, the center in the pons, it coordinates these impulses coming from below and also from above, and then achieves a normal process of urination. And in addition to the pontine micturition center, we have cells coming down. You can see here the parasympathetic nerves. So if you see, this is a section of the spinal cord. You can see the back portion and the front portion. You have several areas in the spinal cord where the cells, they are concentrated. We call them nuclei. So in the middle part, we call that intermediocell nucleus. And that is the place from where the nerve fibers, they come, and they're called parasympathetic, which is a part of autonomic nervous system. And they come, they reach the bladder. This is the bladder. They reach the bladder through the pelvic nerves. The pelvic nerves, they supply the muscle within the bladder. The muscle in the bladder is called detrusor. This is a medical term, so detrusor muscle. So the normal functioning of that muscle of the bladder is dependent upon intact parasympathetic nerve supply coming from the lower portion, so yes, 2, 3, 4, the sacral portion of the spinal cord. And then you have the sensations from the bladder, which reach the spinal cord through the sympathetic nerves. So you get normal sensations that are conducted to the lumbar portion of the spinal cord. And you also have what is called the Pudendal Nerve, which is a part of, we call it somatic nerve. It is basically, it comes from the same part of the spinal cord from where the parasympathetic nerves come, but it is the nuclei, the cells, the concentration of the cells is located in the anterior part of the spinal cord. So from there, the cells, these nerve cells form, and then they reach the muscles below the bladder. This is called the external urethral sphincter, and then the levator ani muscles. These are the muscles below the bladder, and intact functioning of these muscles is also very, very important to have a normal continence. You know, why we don't leak urine just like that? Because we have a well-functioning, the external urethral sphincter, the muscles surrounding the urethra, and also at the bladder neck. And so these, the sphincter muscles are supplied by the Pudendal nerve, which comes from this part, sacral part of the spinal cord. So there's a very intricate system. You need to have an intact and well-functioning the nervous system, including all these parts of the lower urinary tract innervation, to have a normal urination. So these are the various types which are classified under Parkinson, which was already discussed, and we'll be concentrating on the multiple system atrophy. And this is some epidemiological data which was already presented, which makes my job much easier. This, I won't be talking much. This was already discussed. And this was all, Dr. Golby has already presented this autonomic nervous system. We have the parasympathetic and sympathetic part. And then coming to the bladder problems, one of the most common bladder problems in patients with MSA, also in Parkinson's, is you'll be running to the bathroom all the time. So because of the overactive bladder, the neurogenic type of overactive bladder. So you can have various types of urinary problems, like the urinary frequency. You need to go more frequently, both during the day and night. You can have urgency. You need to rush to the bathroom all the time, very fast. You have to go. If you don't go fast, you may leak urine on the way. And you can have retention. You may not be able to pee. Or you can have a weak bladder muscle, detrusor muscle. And that, if you have any of these, when there is, it can result in very high amount of urine remaining in the bladder after you empty. So you are not effectively emptying the bladder. So, and in addition, it's a very important part of the genitourinary problem in patients with MSA is erectile dysfunction. It's very, very important from the quality of life point of view. And we can certainly treat any of these, either urological dysfunction, or if there is an erectile dysfunction, we have several treatment options available which can really improve the quality of life of these patients. So we can have like any part of the nervous system which can be involved, as was already presented earlier, the thoracic part of the spinal cord, or the sacral part of the spinal cord, and then the brain stem. So this is very, very important for you to understand a little bit what happens, why you develop different types of bladder problems. For example, you can have involvement of the brain stem, which is the midbrain, pons, and medulla, or you can have abnormality in the middle portion of the spinal cord, which I showed in the earlier picture, or you can have disturbance in the innervation, nerve supply, at the level of the bladder neck, means where the bladder is joining the urinary passage, bladder neck. So there can be a problem there. The sympathetic nerve supply should be intact for that bladder neck to work properly. If it is not intact, the bladder neck will be open, and if the sphincter muscle around the urethra is also disturbed, there is a loss of innervation of the sphincter muscle, then you can have incontinence. And if you have only the sphincter denervation, the sphincter muscle is not working because of this somatic nerve supply, the Pudendal nerve problem. then you can have stress incontinence, in both sexes. And most often you get what is called the brain stem involvement, midbrain pons medulla, you get overactive bladder, and you get what is symptoms including frequency, urgency, and urgent continence. So you can have the urinary symptoms and the autonomic symptoms together or separately. And most of the times you see the urinary symptoms, if both of them are there in a given patient, so the urinary symptoms occur first, and then orthostatic symptoms occur somewhat less commonly as a first feature, and sometimes both of them will be there simultaneously. So this is how I differentiate when the patient comes to see me in the office. Many times the diagnosis is not correct to start with. And it's very important to differentiate these two conditions, the Parkinson's disease and then multiple system atrophy, from the urological standpoint too, because the treatment again is completely different. For example, if you take the urinary symptoms, the bladder problems, is much more early in patients with MSA, is much more late in Parkinson's. And the prevalence of these various types of urinary problems is more in MSA. And you see the urinary incontinence. There are various different reasons why the patient can be incontinent, but again, all of them are again more common in patients with MSA compared to Parkinson's. And then the high residual urine, once you empty the bladder, you retain a lot of urine. You're not emptying the bladder completely. And that is very common in patients with MSA. And erectile dysfunction is also very early and very severe sometimes. And then the urinary symptoms often they precede or occur along with the neurological symptoms in MSA, whereas in Parkinson's, most often these symptoms, urinary symptoms, they follow several years after the neurological problem starts. And then when the patient comes to us, what we do is as I said earlier, we need to qualify the type of bladder problem before I recommend any type of treatment. And how do we do that? By doing some tests, special tests. One is the most common test is Urodynamic Test. It's basically a functional test of the bladder to see how the bladder is working, how the bladder muscle is working, or how are the muscles below the bladder, are they spasmodic, or is there any, is the bladder weak, why the patient is leaking urine, is it because of weak bladder, or is it because of the weak muscle below the bladder, or is it a combination? So because the treatment again depends upon what the patient has. So this is the machine which we use for urodynamics to see how the bladder is working. It's a very detailed test, takes about an hour or so, and it gives a very comprehensive information about the entire lower urinary tract, which is very, very helpful in treating the patients, in diagnosing the problem and treating the patients. So our objectives in treating the bladder problems in MSA, they include good control of urinations to treat the incontinence and to achieve complete bladder emptying. And then we need to protect the kidneys. Yeah, we don't want patients to go into chronic renal insufficiency if it can be avoided. So one of the things is that we do some assessment of the urinary symptoms to see what type of the urinary symptom is bothering the patient mostly, which is called the American Urological System Symptom Score. Basically, it will gives us a quantitative assessment of the urinary trouble to see how frequently the patient is going to urine, then how many times in the night, is the patient has urgency, they need to rush, is there any leakage of urine, or is they need to strain to urinate, or is it emptying the bladder completely, or how is the flow of the urine, is it weak or strong, and all these things. And then we do what is called a cystoscopy. So once we assess clinically, of course we examine and see if there is any enlargement of the prostate. The same patients with the MSA can also have prostate enlargement. It's important to know whether it is there or not, because the treatment also has to be directed towards the prostate enlargement. So we do what is called the cystoscopy. So you see, this is an internal view of a telescope, very thin telescope, which we insert into the urinary passage to look inside the urethra and the prostate area and the bladder. And this is one of the patients where normally this passage should be wide open like that. So now you see one of the parts of the prostate is enlarged, which is blocking and asymmetrically compressing the urinary passage, the lumen of the urinary passage. So we can diagnose that this patient has prostate enlargement in addition to MSA, if he was diagnosed with MSA. And sometimes you can have what is called the stricture. So this is the bladder, the urinary passage. The urinary passage in male is longer compared to a female patient. It's about 27 centimeter in men and 4 centimeter in women. So there can be blockage at any part of the urethra. So if we don't diagnose this and we treat the patient with medications, the urinary symptoms, especially obstruction, may not improve unless you diagnose that this is there. And the cystoscopy is the investigation which we use to diagnose this problem. Sometimes the bladder may be very, very thick. You see, normally the bladder should be smooth. You don't see these rugations or the folds in the inner lining of the bladder. So if we see like that, means the bladder is overworking. So if it is overworking, then we need to see is there any blockage, either at the level of the bladder neck, where the bladder joins the urethra, or somewhere below that. Or is it a functional problem? And then this is like a pictorial diagram where this is the bladder, and that's the urethra, the urinary passage. You can have in MSA, like many of the other neurological problems, you can have very overactive bladder and also an overactive urethra, the muscle around the urethra. We call that sphincter dyssynergia. We can have overactive bladder, overworking bladder, and normal urethra. You can have a normal bladder, overworking urethra, urinary passage. You can have the normal bladder, and is very much dilated urethra. And there is the loss of innervation at the junction of the urethra and bladder, where there is a sympathetic nerve supply is defective. So you can have different types of problems. So if you have, let us say, the bladder is overactive, is overworking, and then the urethra is normal. So this happens more often when there's MSA involving the brain stem, the midbrain, pons, medulla. So then you can have the frequent urination, urgency, the patient needs to go fast to the bathroom, or sometimes if it doesn't make it in time, he may leak urine. Or you can have a normal bladder but overactive urethra. So in those cases, patients cannot urinate. You need to strain or push, and the flow is very weak. We call that dyssynergia, the sphincter. And in those cases, patient will be retaining urine, a lot of urine. You need a different type of treatment than the patient who has this type of problem. Or you may have both, and you may need medication or treatment directed both towards the bladder and also the muscle around the bladder. Or you may have a weak the urinary muscle around the urinary passage, and in that case, we may do a surgery where we augment the resistance around the urethra so that the patient will not leak urine when he coughs, laughs, or sneezes. And when we do that urodynamic test, which I discussed earlier, we get different types of patterns, just like EKG, somewhat similar to that. And then we diagnose the problems depending upon the type of the curves which we get on the urodynamic test. This is just an example of one of the most common problems we get in patients with MSA. Normally, the bladder accommodates urine at a very, very low pressure. The pressure inside the bladder, till it reaches the capacity, should not increase. If it does, it's abnormal, and that's what we get in patients with MSA. So our treatment in those patients is aimed at reducing the pressures within the bladder during the filling phase. And sometimes you can have the pressure will be high, and then the bladder becomes more irritable. It contracts all the time. Normally, when the bladder is getting full, it should not contract till it reaches the capacity, and when you find a congenial place to empty the bladder. If it does before that, we call that overactivity, and that also a patient can have symptoms, and that can be corroborated by this urodynamic study. So you can have both, like in this patient. And this is another case where normally when the bladder contracts, when you want to empty the bladder, the muscle below the bladder should relax. so that there is a coordination between the bladder and the urethra, so that the bladder empties completely without any problem. For example, these two are not talking to each other nicely. They're fighting with each other, the bladder muscle and the muscle below the bladder. If they're fighting with each other, then the urine will not come out effectively. The patient retains a lot of urine, and that's one of the reasons for urinary retention. So sometimes, if you don't do the test, for example, the urodynamic test, to show that the muscle below the bladder is working normally, when the patient tries to empty the bladder, it should be like a small line. Here you see so much of activity. So it means the bladder is working, the bladder is contracting, and the muscle below the bladder is also contracting, so it's not allowing the urine to come out. If you don't do this test, for example, you may think the patient has prostate enlargement. You give the patient medication for prostate, and the patient will never improve. And because of the high pressure within the bladder all the time, the kidneys can get damaged, so you can have renal dysfunction. So very, very important to diagnose the problem accurately in these patients. It cannot be overemphasized. And we also check what we are thinking is correct by instilling a dye within the bladder. We call the video urodynamic study, where we instill the dye and we take an X-ray at the same time. So we are proving that what we are thinking here, that the muscle below the bladder is overworking, is not allowing the urine to come out, is shown by the visual picture that the urine is not coming out. So there is a blockage, there is a functional problem because of the muscle spasm below the bladder. So we direct the treatment to treat that problem. And if it is not treated well, you see the bladder normally is very smooth, and you can see so irregular and sacculated, and that is a very bad type of bladder in these patients. So you should not allow the patient to reach this stage. Then how do we treat? So basically this flow chart shows basically what all things can go wrong in the urinary tract, in the lower urinary tract in patients with MSA. You can have an overactive bladder. The bladder becomes irritable, contracts during the filling when normally should not. So then the patient will have frequent urination, urgency, they have to rush to the bathroom, they leak urine all the time, or they can have the bladder muscle and the muscle below the bladder are not coordinating, so you get dyssynergia. You can have the patient retains urine, a lot of urine. And sometimes when the parasympathetic nerves are not working normally, the bladder muscle cannot contract, so that it cannot empty the bladder effectively. So in those cases also, you get large volumes of urine. The patient will not empty the bladder completely. But it's very important to differentiate that these two conditions, both of them, the end result is the same, ineffective bladder emptying, but the reason is different. So it's important to diagnose this. Again, we diagnose this by urodynamics, and then we treat selectively whether the patient has dyssynergia or whether the patient has a poor contractility, the weak bladder, or the patient has a denervation of the sphincters, the muscle around the urethra which normally maintains continence, that you don't leak urine when you're walking, normally because that the muscle around the urethra is continent, it's strong. If that is weak, which is also very common in patients with MSA, then our treatment should be directed to improve the function of the muscle around the urethra so that the patient does not leak. So if the patient leaks, it does not mean that the problem is at the level of the brain stem or higher centers, the overactive bladder. The patient may leak here, may leak here, may leak here. So patients with the leakage of urine can have any of these problems. We can't just treat because the patient is leaking, give the treatment. So we need to find out what exactly is the reason for the leakage and then direct the treatment towards that. Let us say the patient has the overactive bladder, the problem with the brain stem and the higher centers. We treat the patients with medications like oxybutynin, tolterodine. Then we have a lot of these medications, anticholinergics. We have solifenacin, darifenacin, trospium, so many of them. And last month there is another new medication which is approved by the FDA. It's called miragabron, which is one of the medications which is supposed to be having less side effects. All the medications like oxybutynin, tolterodine, they have got dry mouth, constipation, blurred vision. There's a lot of side effects, especially when you use this medication for a long time. And this beta-3 medication, which was approved last month by the FDA, has been found, I mean, at least in the preclinical studies, found to have less side effects. So there's a lot of scope in using that medication. And then when the patient has a very high amount of urine remaining after emptying the bladder, so not emptying the bladder completely, what we do is, depending upon the quality of life, if the patient is too much, has a lot of other morbid conditions, what we do, either we insert a Foley catheter for some time, or we teach the patient CIC, intermittent catheterization, which is done by either the patient or the caregiver, or we may also insert a suprapubic catheter, because keeping the catheter in the bladder all the time, it's not safe. It can cause stones in the bladder, it can cause infections. So it's a lot of problems. Sometimes there can be loss of tissue. The urethra will be lost because it's eaten away by the constant irritation by the catheter. So in those patients, what we do is we insert a suprapubic catheter through the belly into the bladder, which may be temporary or which may be permanent. And for example, let us say they have denervation of the sphincter. Sphincter around the muscle around the urethra is not working well, so we can do some surgical procedures. I will just discuss different surgical procedures. Some of them are very, very successful, and the patient's quality of life is very much improved. For example, there is stress incontinence. When the patient coughs, laughs, or sneezes, he will leak urine because the muscle around the urethra is weak. So we can very well treat that problem by very simple surgical techniques, which we'll just show you. This, of course, is the prostate enlargement. You see below the bladder. So it's not that patients with MSA will not have prostate enlargement. You may still have prostate enlargement. You may still need the treatment of the prostate along with the treatment of incontinence from MSA. And so in those patients, when there is a behavioral treatment is also very important. You need to avoid excessive intake of caffeinated fluids, beverages, coffee, tea, excess spicy foods, all the bladder irritants, very important. And it's important to know to have a good collaboration between the neurologist and the urologist for an effective treatment, very successful treatment strategy to be planned for these patients. So when there is a sphincter dyssynergia, which we just mentioned earlier, so how do we treat? For example, we can give the medications like baclofen or Diantrium. But nowadays, what we do is we inject a medication called the botulinum toxin, which prevents the release of a chemical at the junction of the nerve and muscle, so that the overactive muscle, the muscle below the bladder, is relaxed, so that the urine comes out easily. So the bladder empties well. So we call that is basically is an off-label use. It's not approved. It's very likely that it will be approved by the FDA soon. The use of botulinum toxin for sphincter dyssynergia. And the other things we can use, and sometimes we can also use what is called tamsulosin, which is a medication which is used commonly for patients with the prostate enlargement, but this can also be used in patients with dyssynergia. We use them very effectively. These patients, remarkably, they do so well that their quality of life improves so much. And this is how we inject. The injection of botulinum toxin is by putting a telescope. This is a thin telescope through the urinary passage into the bladder, and we inject the medication at different places. We puncture the bladder inside the inner lining of the bladder using a special needle which passes through the telescope. We inject at different places. And then what it does, it prevents the release of a chemical which is released at the level of the nerve and muscle, the bladder muscle, so that the bladder becomes less irritable and relaxed, so that the frequency and urgency and leakage of urine, that if that is the main symptom, those things will improve. And in patients who are refractory to the medications and this botulinum toxin, we have another option, what is called interstim. So basically modulating, changing the way the nerves are working, the interstim. So again here, the interstim for this indication is not approved by the FDA at this time. And again, there's a lot of talk going on. It's very likely probably in the next few months it may be approved. But we still do off-label with counseling the patient appropriately. It's very effective if it is used in the right type of patient. It's very good for patients with sphincter dyssynergia, and also if you have a non-obstructive retention. If you have a urinary retention, but the prostate is not enlarged, so we call that non-obstructive retention. And also in patients with very severe frequency, urgency, your medications are not working, or if you have a lot of side effects with these medications, again, InterStim can be used. And this is how we do the InterStim treatment. So basically, this is just like a pacemaker. It's a bladder pacemaker. What it does, and this is we call that a lead. It's a very thin lead. It's the back of the patient. This is the tailbone. We pass this lead under X-ray guidance into the third hole, which is on the tailbone, on the back of the tailbone, while the patient is lying on the bed in the prone position. And then we stimulate this lead, and we see some contractions of the muscle around the anus. So that is to confirm that the tip of the lead is in the proper position. Once we confirm it's in the proper position, we connect that to this generator, and this generator is placed below the skin on the buttocks, on one side of the midline. And that it modulates, it just controls the disturbance in the innervation on the bladder, so that the urination becomes normalized. And that's how it is done while patient is lying down on the bed, and we insert the needle and we pass the lead, and that we connect that to the generator, which is placed in the buttock region here. And then sometimes the patient will have more urination in the night, and we treat that with desmopressin. And of course, very important to know that the sodium levels are measured while the patient is on desmopressin. And if the patient is in retention, so the retention can be because of the sphincter dyssynergia, which we just mentioned, or there may be prostate enlargement, or the patient's the bladder is weak, so you have to treat accordingly. For example, if the bladder is weak, then we don't have good medications to give a jump start to the bladder. We don't have anything like that. So in those cases, we do what's called clean intermittent catheterization. And if you have dyssynergia, I mentioned these treatment methods, we can do that, including InterStim, neuromodulation. Or if you have prostate enlargement, we will do what is called transurethral resection of the prostate, TURP. Of course, if the patient is very morbid and a lot of other medical problems cannot withstand the surgery, we can insert the catheter, urethral catheter, or a suprapubic catheter, which may be temporary or permanent, depending upon the situation. And then we can inject the botulinum toxin into the sphincter muscle around the urethra in patients with dyssynergia. And we can put what is called stent for the same reason. When there is dyssynergia, when the patient retains a lot of urine, we can put in a stent, means basically a device which is placed inside the urethra to keep the urethra open so that the bladder is empties completely. But in these problems, patient has to wear a bag which may not be liked. Some of the patients may not like that. And the sphincterotomy is when the sphincter is dyssynergic, it's not coordinating with the bladder well, then we can cut the spasmodic sphincter by a telescope inserted through the urethra using a laser knife, which is again also very effective. So depending on the type of problem, we can help these patients very well. And this is what I was telling about the stent. So it's basically like a net device, a short device. This is the most proximal portion of the urinary passage. That's the bladder, that's the urethra. And here there is a sphincter spasm. So because of that, the bladder is not emptying well, so we put the stent here. So the obstructive part is relieved, so the urine is drained completely. And you can do a laser cut of the muscle around the urethra. You can use a cold knife and just cut it. Whichever way we use, these are different types of energy which we use during surgery to open up the sphincter. Or we can insert a balloon, just like a cardiac, the coronary balloon angioplasty. We pass a balloon into this area, and we just dilate that so that the passage is open, and you can have stents. And then this is how we inject. The muscle is very, normally it should be open like that. And here you see the difference. So the muscle is so much spasmodic. So it prevents the urine from coming out. What we do is we insert a telescope and a special needle through that and inject this muscle with botulinum toxin, so it becomes relaxed so that it empties the bladder well. And then in late stages, of course, indwelling suprapubic catheter or urethral catheter when the patient cannot withstand any other type of surgery. Usually we try to avoid doing TURP in these patients, prostate surgery, because in MSA you have very often patients have incontinence, the leakage of urine, because of the various reasons. When you do the TURP, they remove the enlarged portion of the prostate, their patients are very likely to have leakage of urine, which continues even after surgery. So if you don't know what the pathophysiology, what is the problem, what can happen, then you will not be happy after the surgery. So we don't want the patients to be happy. So we always discuss what type of the problem can be there in patients, especially patients with MSA. I see many patients who underwent TURP without proper evaluation, and the patients obviously was unhappy. So it's very, very important to find out whether you have what type of problem. Is it prostate enlargement or neurogenic bladder, or do you have both? And sometimes, when the patient is leaking urine, when you cough, you can leak urine for one different reason, where the muscle around the urethra, which normally prevents leakage of urine, is weak. In those patients, what we do, we put a sling. This is a sling made up of cadaveric tissue, human cadaveric tissue. We make a small incision below the scrotum and then expose the urinary passage, and we put it around the urethra. So this increases the pressure on the urethra so that the leakage of the urine when you cough, that will stop. This is helpful in mild cases of leakage of urine, but if we have quite a severe leakage of urine, we put what is called a sphincter. It's called artificial urinary sphincter. It's a very, very effective, highly successful treatment. This is a synthetic device. They're made up of silicone, a type of polymer, and then so it has got 3 parts, and everything is inside, nothing outside. This is called pump, this is called reservoir, this is called the cuff. This is like a cuff around the urinary passage we put around the urethra, and this we put below the skin on the abdominal wall, and this is the pump, we put it inside the scrotum. So when the patient has to empty the bladder, they have to press this pump so that the urethra is opened up by the cuff, and then the urine comes out. It takes about 3 minutes and to empty the bladder, and then again automatically, because of the valvular system, the urethra closes so that the patient will not leak urine. The highly successful treatment, again, if it is done for the right type of patient. And if the patient has a very severe type of overactive bladder, to the extent that the pressure is so high within the bladder, the kidney function starts deteriorating. In those cases, no medication will work. And here we have to do what is called augmentation. So we increase the capacity of the bladder. The bladder becomes contracted and small in these patients. So to reduce the pressure within the bladder, we open up the bladder and take a small patch of intestine, a small gut, and then separate it from the rest of the bowel, and then put it over the bladder. This is the bladder. We open up the bladder. This is all by doing abdominal surgery. And then we take that patch of bowel and stitch it to the bladder so that we increase the capacity. Whenever we open the bladder and put something inside like that, it increases the capacity and reduces the pressure. So when the pressure in the bladder is reduced, the back pressure on the kidneys is also reduced, so that at least we will prevent the deterioration of the renal function, deterioration of the renal failure. And then we can also do, this is an intraoperative picture, how it looks. This is the bladder part, which is opened up. Normally it is not so thick. Normally it's very supple and soft, nice looking, but here it is so thick because of this patient actually is an MSA patient with a severe overactive bladder. And then we took a part of the bowel, which is opened up, and we are stitching the bowel to the bladder to increase the capacity and reduce the pressure. And sometimes what we do when the bladder is like an end-stage bladder, you cannot repair that bladder. It becomes so severely contracted and small. In those cases, we cannot salvage that type of bladder. In those cases, what we do, we take a pouch of, we take a small bowel, separate it from the rest of the bowel, and then we cut the ureters, the tubes coming from the kidneys. We cut the ureters away from the bladder, and we attach that both the ureters into a pouch of bowel, and we'll make an opening in that bowel and attach that opening to the skin, like an ostomy. So the patient will be wearing a bag, and at least one thing good is the kidneys were protected, and then you are free. The bladder is completely separated from the rest of the urinary tract, so that it won't form what is called pyocystis, means collection of pus inside the bladder. So that is one of the problems, complications of end-stage bladder disease, which we can get in these patients. As I said, this prostate surgery should be avoided in patients with MSA unless it becomes so mandatory that it is so much enlarged, and then you don't have, the medications are not working, for like tamsulosin or any other alpha blocker medications. And it's very, very important to do the urodynamic study in these patients, as it cannot be overemphasized to know what type of problem is there in addition to the prostate enlargement. And it is very, very, very important to realize that the urinary symptoms may still persist after the prostate surgery, and they certainly need additional medical or surgical treatment even after prostate surgery. So these are the reasons where we come into picture as a urologist. If there is some blood in the urine, obviously we have to find out why there is blood in the urine. You have erectile dysfunction. We can treat with medications like sildenafil. There are several medications. And we can also do the surgery when the medications are not working. And it's very, very important in MSA. Dr. Chilimisky has already discussed about the autonomic symptoms. You can have orthostatic hypotension. One of the problems of using any of these medications for erectile dysfunction is you can have facial flushing and the hypotension. You already have hypotension because of MSA, and if you use these medications, it's possible that you may collapse. So in those cases, when the hypotension is so severe, we cannot use, and in those patients, we recommend surgery. We implant penile prosthesis, which is very successful treatment, but only thing is it requires a surgical procedure. And if you have a worsening kidney function or dilatation or swelling of the kidney, then you have to immediately attend to the problem. You cannot just treat those patients with medications. You have to take care of the pressures in the bladder, reduce the pressures by one of the surgical treatments which I just mentioned. And if the medications are not working for the overactive bladder, then of course either you treat with the botulinum toxin or the interstim. Of course the latter is off-label. And if you have incomplete bladder emptying, we have to know, is it because of weak bladder, or is it the prostate enlargement, or is sphincter dyssynergia? So you treat them accordingly. So the bladder problems in MSA, they require a very detailed assessment, and then they've customized treatment according to what type of problem is there. And then BPH needs to be excluded in all patients with MSA with bladder problems. Urodynamics is very, very helpful and very important to do before you start the treatment, especially when the initial medications are not working. And the goal of treatment of the bladder problems is we have to preserve the kidney function, and we want to treat the leakage of urine. We want to keep the quality of life very high, and we want to achieve a normal urination and complete emptying of the bladder. And we need to follow up these patients with the kidney function assessment and then a periodic urodynamic assessment to see whether the bladder function has improved and improved. And then very important to have a combined management of by the neurologist and the urologist. And that's it, that's that.